All right, welcome back, everyone. Shaun Brewster and Bodine Ledden here today. Well, today we're going to talk about a topic that we are always harping on about in our courses, and it's the danger of being purely passive in our treatments. This is an important topic, I think, for everyone.
Yeah, 100%. When we think about patient coming in with a problem, they can't reach, they can't bend, they can't play sport, whatever it may be. We've got to integrate passive treatment through to active so that they can return to what they enjoy doing or what their goals are.
Perfectly stated. Yeah, I think we tend to have a tendency, and when I say we, I'm going to say the group of therapists out there that are working primarily in soft tissue type treatment work in the manual therapy space. A lot of massage therapists, remedial therapists, myotherapists, some physiotherapists, even some osteopaths, and chiropractors, I guess we all can fall into this category where the patient will come into the consultation room with a problem and say, like you said, I have difficulty bending forward, I have difficulty pressing a weight overhead, or I have pain when I'm doing something. We go, fantastic, let's do some assessment, put you on the table, and then we can kind of do things to the patient. We treat them, do things to them, and then we expect them to move from this dysfunctional state to a functional state purely through this passive exchange, this one-way exchange of us providing treatment. And that's a very two-dimensional approach to treatment, isn't it?
Yeah, for sure. And I know when I first started out, someone would come in with those problems and you're sort of like, all right, well, don't bend forward or don't reach overhead or, avoidance. And it's so incorrect. We really want to encourage them to move towards those painful movements or towards those limitations so we can desensitize them, decrease their fear of movement and promote their recovery. So I think that's fundamental. We can use manual therapy really effectively to decrease inhibitions to movement and exercise, decrease their pain, but we've got to get that progression to active treatment in that session and start to progress that over a period of time that we are challenging their movement, we're progressing a little bit further with an active intervention and not just keeping the treatment purely passive.
Yeah, definitely. And I think most people who know us well will know that we are probably the biggest advocates of manual therapy that they'll ever meet. And so I wouldn't want anyone listening or watching this to think that we're saying passive therapy, manual therapy is not useful, it's not valuable. It absolutely is, but it's got its limitations, just like everything. In the same way that exercise has its limitations. If somebody come in and they've got some kind of chronic pain presentation and you say, here, I need you to do these movements, these exercises to solve your problem, it possibly could, but the person's going to have so much fear avoidance initially, if they've been carrying this pain around for years, that the idea of going from I can barely move to doing those exercises you just gave me is incomprehensible for some of these patients. So this is where our manual therapy comes into its own. So we can come in and go, let's try some dry needling. Let's try some joint mobilization, some massage, some TENS, some whatever it is to reduce, like you said, your sensitivity to movement and to pressure and to whatever it might be, to get you to the point where you feel comfortable in your own body and maybe confident enough to try some movement. And so it's kind of like the first aid kit. That's how I like to think of it. It's a first aid kit. It helps you manage, stop the bleeding. In other words, stop the pain, stop that fear, the apprehension, those kind of immediate danger impulses that our body's giving us when we have pain. So we get past that and into the healing. And you can't massage, mobilize, needle, tape, electrotherapy applications to the point where you can heal. You can't heal tissue with these techniques. All you can do is improve the ability of that person to move more, to have less pain, to have a better experience in their body. And then the healing has to happen naturally. And exercise and movement is one of the best ways to support that.
For sure. And not only thinking it from a structural point of view, we think about the neurophysiological mechanisms associated, the neuroplastic changes that can occur. So when we look at a manual therapy approach, for example, joint mobilization, where we can have these neurophysiological changes that occur at the location, also at the spinal cord segment. So we can have segmental inhibition. We can have descending inhibitory control. We have changes in sensory motor input and output. So we have various mechanisms at play there that can decrease someone's pain. All right. Then we've got to get them doing the movement that they came in with a problem doing. So if we can get them to do that in a pain-free environment or a reduced pain environment, that can improve their confidence with movement. But the more that we repeat that, that can create these neuroplastic changes. Now, remember when someone has pain, right? They'll have a learned non-use. So they learn not to use it because the brain is essentially, it's working as a protective mechanism to prevent further damage or injury. So when someone expects to have pain reaching up overhead or bending forward, they have this pre-programmed perception that movement is going to be painful. So they'll come up with either an avoidance pattern or behavior or a different way of moving. So they learn that. And the more that they learn that, that can lead to deconditioning. It can lead to, again, more fear. So if we can use manual therapy to modulate their pain, then take them through the movement that they had the problem with and repeat that, that can create these positive neuroplastic changes, right? And giving them confidence and reassurance in the way that they move. Again, the more that they do this, those neural pathways and synapses start to become stronger and more efficient. And that's how we can sort of break those bad habits, those old pre-programmed ways of moving in pain, and create these positive neuroplastic changes.
For sure. And I think that's another way to describe what you're sort of saying there is like success breeds success, which we often say when we're talking about, how to take somebody through or progress them through exercise or through their pain. And so if you can find someone who has difficulty reaching overhead, like you said, it hurts their shoulder when they do it, but you can find a way for them to do that. If you can say, okay, lifting her up to the side hurts. What if you lift it forward and up? And they go, well, yeah, that's less painful, or it's fine. Okay, well, let's do that a bunch of times. And then just bit by bit, let's see if we can move that arm slightly further and further out. So they're not jumping straight into the thing they have trouble with. They're starting with a successful movement. It's successful in that they can achieve it. It's not painful, and they feel confident with it and comfortable with it. And then bit by bit, you nudge that barrier, physical barrier that they have created for themselves or the injury has created for them. More importantly, the mental barrier that they've subconsciously created. And it's not there. We have to emphasize this to our patients too. They haven't made up their pain. They haven't imagined it. Their brain has put in these protective mechanisms in place so that they don't damage something that they think is already damaged, or further damage something that's already damaged. And so if you just nudge that barrier out bit by bit by bit, we see people achieve things that they couldn't possibly imagine. And I'm sure everyone here's seen examples of this clinically, where you'll have a patient says, I can't lift my arm up above my head. And then as they take their jacket off in the change room, and then they in the consultation room, and then they hang it up on the wall. And what did they do when they hung it up? They lifted their arm above their head. They're not thinking about their pain. And so getting them to do things in a different context, in a different way, in a successful way, not focusing on their shoulder, but focusing on a task, is a surefire way to help nudge those pain barriers out, perceived barriers out.
Yeah, changing that input. I had a fantastic case the other day. Patient was describing he gets this spasm and a lot of pain when getting out of bed on the right side of the bed. So I got him to lay on the table and get off the table to show me the pain that he experienced, and had this spasm come on. So we went through some basic sit to stand MWMs. So applying that mobilization in a sit to stand. Well, before that, I got him to sit to stand and show me how he would do it. And there was a lot of apprehension and this sort of expectation of pain. Just by changing that input, supporting him through that movement, 6 reps, and he was completely blown away about the changes. And I got him to then just repeat that on his own quite a few times, showed him how to do it himself. Completely blown away that the changes that occurred. And it's not that I pushed anything back into place or anything like that, but we changed the input, we changed the beliefs, we reduced the fear and improved the confidence with movement, and that reassurance that, this is how we can move in a safe, comfortable way, and movement's actually good for you. But he was so braced and guarded beforehand because he was expecting and anticipating this movement. Now, that's a great example of moving from sort of a passive through active. But, if you just did a passive intervention, lay down on the table, press and poke, and, you might get a decrease in some symptoms, but the issue is actually getting out of bed.
Yeah.
All right. So going from that to laying down to actually sitting and standing up. So we've got to sort of be a bit more targeted and specific with that approach. Like, yeah, we'll have some effects as I mentioned with those mechanisms before with a manual therapy, but we could be a little bit more focused and specific with that approach.
Yeah, 100%. And you've got that patient. That's a really good example where, they have pain getting out of bed in that way. And for someone who doesn't understand their body really, really well, they'll think, okay, some tissue, some part of my body that I'm using when I do that is broken, it's damaged, it's torn, it's inflamed, it's something, right? And then simply by demonstrating to them that they can do it without pain, by applying some pressure, so some manual therapy to desensitize tissues, to change load on tissues in a way that they can do it and realize that actually nothing's torn, nothing's broken, nothing's probably even inflamed. And maybe the tissue is just a little bit sensitive. And so you reduce that sensitivity, show them what's possible. And I see this time and time again in some of the courses we teach and with patients. You'll do something, someone has a painful movement, you change the load on the tissue slightly. You haven't fixed anything, you haven't popped a joint in or out, nothing's different. You just change the load on the tissue. And immediately the pain's gone and the movement's better. And they think it's magic trick. No, it's just we remove the thing that was holding you back for a moment in time. And now how do we replicate that? How do we make that play out over time so that the patient can have longer lasting effects? That's the goal. That's the hard thing to do. But it is absolutely possible if we move away from just this passive interaction.
Yeah. And then, we think about that as that transition of passive through active, but then then where do we go from there? Well, yeah, we show them how to recreate that at home, but then going forward in long-term management, there needs to be this progressive approach. It's just like going to the gym, the basic S&C principles of progressive overload, allow time for adaptation, and continually overload so that the tissue adapts and responds to the applied stimulus. And that's classic. If someone is moving from sit to stand and that's where they're getting their symptoms, well, let's start to increase the volume of how often how many repetitions they do, the frequency, how often per week or per day that they're doing that, and then the intensity of how much load or weight is being moved. So you can start to use that in an exercise. So you don't need to be, the best strength and conditioning coach in the world. You just think about, well, what movement do they need to do, and how do I apply basic principles to increase the capacity of their tissue so that they can withstand these basic movements?
Yeah, definitely. And I think there's even a bigger problem with the purely passive treatment is that the whole therapist reliance issue. And we did a podcast way back a while ago on over-treating patients. And this is where you fall into the trap of over-treating, is when the patient comes in and you give them a passive type treatment and they feel great. And, we can't take away from the value in passive therapy. That it definitely has a valuable place in society, and there's a need for it. But if that's all we do, someone comes in with especially a chronic pain presentation or a movement limitation or movement deficit, and we provide a passive input to a functional problem. So there's two opposite things there, passive and functional, two opposite things. Then they'll have a reduction in symptoms for 3 or 4 days, whatever it might be. And then the inputs that created the problem in their life are still there because it's at work and home and stress and whatever else. And so 3 or 4 days later, they phone us up and go, yeah, it's starting to come back again. When can we come and see you again? And you go, brilliant. Here's my business model. Come back in next week, please. And then it turns into a revolving door. The same bunch of clients coming back week after week because they're relying on that magic pill that you're giving them with the passive treatment. And it is a magic pill for 3 or 4 days, but that's not a solution. Right? I just want to say one more thing on this passive treatment, which is if you're a therapist who provides that type of treatment, as in patient lays on the table, you do things to them, they go home, they feel good. That's still a really useful thing. We can't take away from the value of the patient who is, their body's in a sensitized state. They've got high levels of stress in their life. They're anxious about something. They crave physical touch. So much of us in society don't have that physical connection with another human being. They like the interaction with you, the talking, the banter, the conversation, the trust, the rapport. That's hugely valuable.
Yeah.
For generations before us, that was the confessional booth at the church. We don't have that, so much in our society anymore. It was the uncle or auntie that you go and spend time with on the weekend and have that introduction. Building that confidence, that feeling of safety, it's still massively important. So we're not saying that that's not useful. If that's your model of treatment and your model of clinical practice, more power to you. If you've got a patient who's got a functional deficit, passive input is not going to be a solution for it. It'll be a band-aid.
Yeah, for sure. It's like those classic widespread chronic pain there's not really a pathology as such. It's widespread hypersensitivity. Their nervous system just needs to be calmed down, and sometimes the best case, if someone comes to me like that, I'll often refer on. I'm not the best at giving a relaxation massage. Other people are better at that than me. So there's certainly a place for it, but like you said, those functional problems where we want to start to integrate them as fast as possible into an active program that they can do themselves. And there's, numerous techniques that you can do. It could be joint mobilization. Neural mobilization is a fantastic one early on, and someone's presenting with radicular pain, starting to get their nervous system moving and desensitized to promote them to actually move more and not move less. Because we know the evidence surrounding movement is fantastic. But that is a manual therapy approach that integrates exercise, which is great. You see the same with the functional release cupping, that integrating movement, shifting that attentional focus away from their pain or their limitation, and getting them to repeat these movements multiple times. They get more comfortable, more confident in that movement with less pain.
Definitely. And we often talk about the pain modulation mechanisms that are built into our body, our gait control and our descending pain modulatory pathways. And exercise, as you mentioned before, has been absolutely demonstrated to initiate this descending pain modulation. And so, yes, we can reduce somebody's pain with passive treatments, but if they can reduce their own pain with movement, and it's through repetitive motions, through doing things successfully and comfortably, but it's also just through contracting muscles, moving body, and releasing those endogenous opioids to make you feel good. And it's really difficult to have pain when you feel good. When you're happy, when you're feeling, inspired and good in your own body, it's difficult to have high levels of pain. And so one dampens the other. It's why when, people go to the gym, they come out and they go, I feel so much better after that. Or I wake up in the morning, I'm stiff and sore, and I go for a run and it sucks for the first 15 minutes. But by the time I come home, I've never regretted it. It's always a great thing. One, because your body physically warms up, right? The tissues soften, they become more pliable, and that's good. But two, because we get these endogenous opioid releases, it's a chemical change in our body that actually stops us experiencing the pain. And so someone who's got chronic pain, that is a strategy. Movement is the strategy to manage that pain.
Yeah, not to mention the other effects that go along with that, and I think like when we look at manual therapy versus exercise versus pain neuroscience education, well, none's really better than the other there, but that integrated approach can be really effective. And we think about why we would use one over the other or why we would combine them. When we start to use the manual therapy is a great way to modulate someone's pain and then integrate them into an active approach. Exercise can be fantastic for improving capacity of their tissues, but also the behavioral changes that go along with that. People that exercise often, can have changes to their eating habits, their sleeping patterns, their levels of stress decrease. There's been numerous studies in the brain of upregulation of brain-derived neurotrophic factor. So it's important for learning and memory and decreasing neurodegenerative disorders such as Alzheimer's and the other one, not Parkinson's, Alzheimer's and dementia, that's the one. Maybe I've got a little bit of it myself. But, fantastic evidence for that. When you think about someone who's in chronic pain, they often have signs of mood-related disorders, stress, depression, anxiety. One of the best things for that is actually exercise. So is manual therapy. Manual therapy can be fantastic for decreasing stress.
Yeah.
And, you know, when we again look at that in the whole sort of approach of care for a patient, you know, decreasing their stress can be that gateway to opening the doors to getting them to moving more. So yeah, I mean, I don't think one's better than the other. I think an integrated approach is great.
Yeah, that's right. And some people might listen to this and think, well, if exercise and movement can reduce stress and pain, and manual therapy can reduce stress and pain, well, then what's wrong with just doing manual therapy or just doing exercise? Well, I'd say, you know, exercise is limited in that it's not great at desensitizing tissue quickly, and in a way that is not threatening to the patient if they're already in that fear avoidance. Manual therapy is not great at long-term tissue capacity development. Actually bomb-proofing your body. Manual therapy won't do that. It reduces your pain experience in the short term, and that's really useful so that you can get into that long-term bomb-proofing. But the problem with not doing both things is, or at least staying just in one camp, is that if the patient comes to see you and goes, well, Bo's the guy that reduces my pain, he's my therapist. You know, without him, I'd be really stuck. You know, I wouldn't know what to do. And we hear this so often, you know, from patients and even therapists saying, "Oh, my patients rely on me so much." And it's nice, but think about what that does to the patient's self-efficacy. You know, their ability to be able to go, you know, yeah, I go and see Bo, I go and see Shaun, I go and see whoever to have my pain. Like they settle the pain now when I get really bad. Well, I know that there's things that I can do that will help manage that as well. So empowering our patients through movement, through exercise, through education and other strategies that to help them know that when their body gets like this, there are some things they can do as well. And we're not always going to be available for them, nor should we. You know, if we don't want to be a crutch for them. We don't want to be most that props them up when they really need us. We can help them when they need us, but beyond that, they need to have that self-efficacy, their own strategies to manage pain, and getting them involved in their passive treatments early, showing them that they can be a part of that. It's so empowering for them long-term because they know it's not just us that has the answer then.
Yeah, I couldn't agree more. Like that's one of the best things in a treatment. If you get a good change, let me show you how to do that at home.
Do it yourself. Yeah.
Yeah, so you can do this yourself. This is how you do it. You can record a video of me doing it, whatever it may be. But you know, giving them those tools to be able to treat themselves and be able to take control of the situation, particularly if they do have a bit of a flare up or their symptoms get worse at some point. Yeah, showing them those active approaches is really important.
Definitely. All right. Well, hopefully everyone listening has sort of taken away the crux of this, which is, you know, we are absolute manual therapy advocates. But we, even more than that, we are advocates for an integrated approach that has a long-term view. And the long-term view should be that the patients come to see us at the start. We point them in the right direction. We give them the tools. We give them a map and a strategy, and we say, right, that's where you've got to go. We'll be here to support you. But ultimately, you'll get a certain point down the road. We're not with you anymore. You're driving this by yourself. And you should be able to find your way there. And occasionally, something will happen. You'll have a flat tire, something will go wrong, you'll get some pain, right? Something will go a bit backwards. And then you can come back to us and we'll help you get going again. But it's you that gets you there. We can't co-pilot that patient all the way through to their solution. They have to be the driver. Yeah. And so this idea of passive therapy being a danger, it's only a danger if that's all you do. If your goal to provide a solution, if your goal is to make a person feel good, then that's okay. Right. There's absolutely a role for that. If you're looking for a solution, it needs to be patient driving that process with our guidance.
Yeah, I agree.
That's it. All right, Bo. I think that'll do us today. Thanks for that, everyone. Thanks for tuning in. We'll catch you on the next episode.
Cheers.